with the whole aim of basically, I believe, not to teach you research skills from scratch. I believe you as practitioners already have essential research skills in place already. So my job really is to identify the skills you already use in the therapeutic space, but fine-tune them so that you can use them as skills to evidence that what you're doing in the therapy room is actually working and is publishable and is needed to grow our profession as a counsellor. Any questions on what I've said so far? No. So hopefully, thanks, Libby. She's celebrating. I really appreciate that. Yeah, so that's my aim for this year. I'm also thinking about other ways to get the message out there as far and wide as possible to the practitioners so that we can get some documents out there published in ACJR or ACRJ, ACA's journal, as well as PACTA. So we can get some publications in there. So we're starting to build an evidence base basically evidencing that who we are and what we do is unique, needed, effective, and evidence-based, so we can grow this profession. Yeah. So how we're going to run this is I'll run through these slides, and hopefully I'm going to try and leave it, run the slides and get this over and done with before the end of the hour, so we've got some time to answer any questions that may have come up during the presentation. So what I'll ask you to do is possibly even, if any questions come up or comments or confusions come up, write them down and I'll try and clear them up at the end of the presentation. Is that okay? Beautiful. All right, without further ado, let's get going. So as I said, I'm presenting the first of 6 seminars, I suppose, as part of this counselling research community of practice. This is its second year running, which is and it's part of the research subcommittee, which is part of the National Heads of Counselling and Psychotherapy Education, a volunteer or an organisation that's main aim is to support the leaders in counselling education, so that we are united in providing quality education to tomorrow's counsellors, and doing that today. So let's get going. So we've got 6 sessions, and today's is going to be really concentrating on your skill as clinical note takers. And I want to really unpack clinical note taking and I suppose fine tune it for the purposes of collecting data that's standardized data, relevant data, credible data that you might want to use if you're intending to publish. So this is all about your, like I said, your note-taking, your clinical note-taking, but we're going to be calling it in this presentation systematic clinical observation, which is something we'll use or we'll learn to use if we want to observe our clients in the therapy room, as well as reflective noticing. That is, you as practitioners reflectively noticing yourself in the therapy room. Both are data sets that can be beautiful and rich and deep and very powerful in types of research, such as case studies or qualitative thematic analyses, or indeed single participant research designs, things like that, which I will talk about later. So yeah, we're going to start from the foundations to build your practice-based evidence. All right, let's start with this one, the black box of therapy. So my notes are basically saying, if you had to prove in court exactly what happened in your last session without using words like I felt, it seemed as, I thought, do you think you could do it? Yeah, not usually, because and I'll talk about that why, because that's the therapeutic, that's the reflective, that's the interpretation stuff. And that's the stuff that possibly won't land very well in a courtroom. So we've got to talk about, unpack that black box of therapy and talk about how the data that you will collect in a therapy room that's relevant for research has to be routine clinical notes that don't obscure what's actually happening, all right? Aren't interpretations, aren't possible those notes that reflect your own interpretation from your background, from your experience, etc. They have to be routine, obscure. And and often in if you're in the courtroom asking to remember notes, often they might have a bit of hindsight bias there. You remember things that fit your theories. So we've got to make the invisible mechanisms of therapy visible and trackable and standardized and replicatable if they're going to be standing up as credible data in a research paper. So I just want to unpack that a little bit more and refer to a thing called the ladder of inference, which is something you can read up about if you read papers by Chris Argyris. He talks about this, the ladder of inference, and essentially it's a model, I suppose, that we all use to try and make sense of situations that we find ourselves in and judge or make decisions about how we're going to act as a result of understanding whatever's happening to us. Now, in the therapy room, we typically go up this ladder of inference quite quickly. We'll observe, if we're on rung one, what we're doing is observing something in our clients. And as counsellors and therapists, we often will observe it and then quickly go to a personal meaning based on our own background, our education, our experience, our years of experience as clinicians, and our culture, and we'll add our cultural and personal meanings to that observation that we've just observed in our client. And then based on that meaning layer that we've added, we will make assumptions. For example, in this slide, you might observe the client crossing their arms, all right? In your culture or in your experience, your understanding of crossing arms means the client might be defensive. And so you come to the assumption that the client is resisting me, and with that assumption, you'll make a judgment call about what you're going to do next in that moment. And in this instance, or this example, you're going to confront the resistance. Well, what I'm going to be talking about today is and inviting you to actually go right back down to rung number one, the observable data, and stay there. Actually, don't move on to rung 2, 3, or 4. So research data has to start and finish at rung 1, at the observable data. All right. So and that's different. You haven't been told that before, because in your education and in your supervision, where you're taught how to use clinical notes, and you're introduced to models like the SOAP model or the DAP model of clinical notes, and indeed sometimes the where internet comes involved, and maybe even I think it's Heidi who's recording the session and turning your clinical notes into the SOAP or the DAP model. They will be an intersperse of some of rung 1 data, but it'll also include the subjective data, so some of rung 2 and rung 3. So your clinical notes, as they stand, are beautiful for ethical record keeping, but that SOAP model or the DAP model, whatever you use, needs to be refined a bit if you want to use your clinical notes for research purposes. So we need to find a model of clinical note-taking that stays on rung 1, just at the observable data. Everybody following me so far? Cool. So we're going to talk about a concept called systematic clinical observations. And if you research this or Google this in Google Scholar, SEO, you'll find a lot of data about it. So systematic clinical observations are basically systematic, and that is it encourages you to collect that rung 1 data in the very same way every time. So that allows comparison. So if you in your SEO note-taking, rung 1 note-taking is always done the exact same way. That is only recording observations, not jumping to rung 2 or rung 3, just staying at the rung 1 level. That allows comparisons. Client 1 crosses arms, and client 2, you might find, also crosses arms. And you might even include observations, objective observations about what you did just prior to or just after that crossing arm. But everything is not an interpretation. It's definitely observation of behavior. SEOs are also auditable. All right. So in other words, if someone else watched your a recording of your session, they would also observe the client crossing their arms. There'd be no arguing or misinterpretations or I think it means that. There'd be none of that, because an observation's an observation. Everybody can see that crossing the arms is the exact same thing. So systematic clinical observations have to be systematic, as in they have to be objective and stay at rung 1, and they have to be very objective and auditable, and well as theory driven. So you're observing specific constructs. That is, they're named constructs. Another name for construct might be variable. But yeah, you're naming known, researchable, known variables that are got a name in the literature, such as microskills, such as affect, such as alliance. So when you, I, or anybody says, oh, the affect was flat, we all know what that word affect is. So your language is very much standardized language that's typically used in the literature. Does that all make sense so far? Yep. All right, let's keep going. So let's talk more about those variables. So what are those things, those observations, those rung 1 data that we're observing? They can be verbal, okay? They can be verbal observations or objective data. You might be recording specific words or specific metaphors or response modes. These are all things that can be researchable as distinct variables. They might be what we know as paraverbal language, such as the tone or the volume or the pace or the duration of the silence that you're observing. So all of these things are things you learnt when you were an undergraduate student. These are all those attending skills, those micro skills, commonly known in the literature. Other variables that belong at that rung 1 level that we don't add interpretation to might be those non-verbals that we observe, such as the kinesics, such as body movements, or those proxemics, such as the space between you and the client. And as well as the facing of the body, or even indeed, I'll even include when I'm teaching in the classroom about non-verbals, their appearance and things like that. You're not making judgment. You might just make a sense that there was an odor. You might say something like that, which is observable, or they presented in a disheveled manner, or they were wringing their hands, just things like that. And the other variables, other class of variables that are appropriate for that rung 1 level of observation might be those dyadic variables. That is the interaction between the two as in the two of the client and the counsellor. Is there are you observing interaction patterns? Is there a synchrony between the two of you, etc.? So these are examples of the types of variables that you might want to be interested in observing in research. Any questions on that? I'm going to ask you now before we go any further. So you notice I'm nodding. Yep, thanks, Lee.
Oh, look, I've got quite a few. I guess I really get the importance of what we're doing. I'm also needing to think about where we're going to get to talk about interpretations at some point. And
absolutely, yeah.
Yeah, great, yeah. And then I'll get some more clarity about what to put where, and both can be subpoenaed, right?
Oh, absolutely, yeah.
So we need to be careful in either space, but just separating out what's observable fact from what's interpretation, basically.
Yeah,
the split screen. Yeah, okay.
Yeah, and certainly encourage you to go to that ladder, Argyle's ladder, which, to certainly understand that as well.
Yeah.
But observations are very much predefined, and you never move from the agreed objective definition of the thing you're observing. It's all, there's no, and as you rightfully said, Libby, no interpretation at this stage, at what I call the data collection stage. Absolutely.
And we're not getting into the observer effect then.
Thanks for highlighting
the quantum field.
All right, so luckily for us, there is a thing called the Hills Counselor Verbal Response Mode Category System. Huge phrase, isn't it? Otherwise known as the HCVRMCS. And I promise you, these slides have references at the end that do include this. And Hills does list 14 typical data response, what he's calling is response modes here, but elements of data that can be observed and therefore researchable in the therapy room. Okay, so it's been done for you. All right, so I have included this paper in the reference list. So for example, you might be asking a question about a particular technique that you might want to introduce into the therapy room, and the effects that that technique has on perhaps, let's just say you might want to, there's so many questions you can introduce into the therapy room. You might want to try and train yourself, I suppose, to introduce minimal encourages more than just asking another open question, rather just using minimal encourages. And so you might, the category is minimal encourages, but you'll have to also decide yourself on how you describe what's an example of those minimal encourages. So Hills does that for you. So he has included it here, that as the verbal and minimal encourager, or the non-verbals, which is the nods and things like that. But you decide for yourself what are the minimal encouragers that you want to observe in yourself or indeed in your client, and that's what you observe. And only those things that you've decided are an example of minimal encourager. But in the literature, deciding that, okay, I'm going to be doing minimal encouragers by calling it minimal encourager and not something like nods, then you're using scientific language. Your language will be picked up and able to be compared, I suppose, to other authors who have also possibly researched in observations that you're observing. So it's very much encouraging you to be standard in your language and what you observe, so that your results can be collated with, compared with, contrasted with other authors. You do want to do that so that you can actually argue in your papers. Are you confirming what's also observed by other clinicians, or are you contrasting? And if it's contrasting, okay, what is about your observations that's different? And if you've defined your variables well and you've defined and described your level 1 data well, it should be evident in your results. What is that point of difference that makes your results slightly different from someone else's? Makes sense so far? Yeah. So standardization of the variables you're observing, and indeed the act of observing itself, staying at that level 1 level, not adding your meaning or your culture or bias to it, which can dirty the data. What we want to do is stick to the facts. So far, so good. And I will share these slides with you so you do have the references, so you can read these papers. Yes, Libby. Yeah.
So a body gesture, a minimal encourage in my culture could mean something else in someone else's culture.
Exactly. So that's why we need to describe it. And you need to, and I love that how you said that in my culture. Also in literature, we and I'll talk about this later, in papers that are published, we will put what's called positionality statements, where we describe who we are, our background, and so that the reader, if we publish, can understand who the writer is, and therefore understand why that interpretation has been given and not another one. Does that make sense? Yeah.
Absolutely. Yeah. And I guess there's just there's a meta question there around, we so often are operating within individualistic modes, not collectivist. So we have this really dominant hegemony imposed on everything, which is what we're going to see in existing data. So I wonder whether we just need to have really correct for that in some way, with cultural humility, with being factual, but also in our analysis, we're going to need to really consider that when we've got people from different cultures. There's a lot in it, right?
There sure is. And there is a lot. I'm so the beautiful questions. And yes, there's lots of spaces in a manuscript, a research manuscript, where the researcher / clinician, the practitioner, does declare how they've collected data in a way that minimizes that bias, whatever bias that is. You've mentioned cultural, there can be others. It's also done, so you declare, but also you follow standardized ways of collecting data, so that you, again, to minimize that individuation, you sort of have a very standardized way of what data you collect and how you collect it, to increase the robustness and credibility of your data, rather than it being, you'll hear me using the word noise or dirty the data. That is adding personalized interpretation onto that data, which can dirty it. Absolutely. Hence why we've got to stay at that level, that rung 1, that bottom rung, observation only, where crossing the arms is not a cultural, just if people cross arms, there's no interpretation on that. It's just an observation.
At this point.
Absolutely.
And then we interpret it, we contextualize, we look for bigger patterns of meaning. Yeah. And that, if that's not talked about today, and I don't think it will, it is talked about in other, when we analyze the data. So we're not going, we're just observing it at the moment. Attempting to be as objective as possible. But anyhow, I won't say anything more, but the elephant in the room for me is that we're nearly all white, and they used to be all white men, and now it's changing, 100%. But 100%. History creates the present, and I'll leave it there.
100% and agree with you. And that's why going off topic a little bit, but diverse research is very much valued these days. So we can get outside of this white supremacist or this white, all research based on white male middle age, absolutely, or the first year psychology student, 100%. Yeah. All right, so how do we, and this is going to answer some of your questions, Libby, how do we collect our data, this standardized data, the observation level 1 stuff, with the known variables that I've just introduced you by Hill's list? How do we do it? And this is where handout 1 comes in. It's called the split screen protocol. Okay, we separate on the left the what, the actual observation, the description, objective description, to the so what, which is the right column. That is the stuff that's going on your head, the interpretation. So we try and separate it out in this type of clinical note. We put the observation on the left and your interpretation on the right, so they're not mixed up. Your interpretation doesn't dirty the data. Does that all make sense so far? Cool. All right. So the split screen, left column, the camera view, right column, the stuff that's inside your head. Yeah. And I want to preface this. The stuff inside your head is not, I'm saying dirty. It's not unwanted though. It's data in and of itself, depending on the research question. And that's why we also need to collect that. But just at least separate it from the objective stuff, the camera view. All right. So I'm just going to go back to that one. Yeah. So what we do, the interactive video recording. So just say that you're watching as a therapist, are recorded with informed consent by your client, a recorded session. You're going to get your split screen SCO, your structured, I've forgotten what that was called, the standardized way of doing your clinical notes. And we're going to have 3 columns. All right. As the previous slide said, the far left column will be the camera view. All right. Now, in the middle column will be the variable as defined by Hill's list. All right. The variable that we're observing, the name of it. And then on the right will be the stuff in your head, the rule. If you write an emotion, all right, I'll show you this. So what we're going to do is we're going to do an example of this now. I'm going to get you to download and upload on your device handout number 1. You should see on the second page a table with 3 columns. I'm going to bring this up myself so I can keep following you guys. So just handout number 1. Yeah. And find you guys. Where are you again? Yep. And it's called the split screen structured clinical observation tool. So on the second, on the second page, the data, so the camera view, you actually write what you observe. Then in the middle is the actual microskill as Hill would define it, such as an open question, a reflection, a period of silence, okay? And then on the right, your analysis. Does that all make sense? All right, that's what we're going to practice on. So on the next slide is a little YouTube clip of a therapy video. I'm going to ask you to fill out, we'll just do the opening phase. You'll notice it says opening phase, middle phase, and then the closing phase. We'll just do the opening phase. So I'll just show 2 minutes and I'll get you to jot down a camera view observation, your interpretation or your initial analysis, which is maybe about rung 2 or rung 3 in that ladder. and then write down what you think is the actual variable as defined by Hill that we're all observing. Does that, any questions on what I'm asking you to do? All right, let me go to the next slide. Let's hopefully this video works. It does. And I'll play this for 2 minutes. All right. There. All right. Let me know if you can hear it when it starts.
Hi Hannah, nice to meet you.
Hi.
So I understand that you were referred to me by your GP because you've been experiencing some anxiety difficulties.
Yeah. Yeah. I guess it kind of started like 5-6 years ago.
Okay.
It escalated a bit. I've just recently moved out from living with my parents, so it's made it a bit worse, I think.
Okay. Is this the first time that you've left home?
Yeah. Yeah, it's the first time actually. Yeah. I was going to a few years ago. I just thought it would be easier to stay at home. So.
Okay. So it's been quite a big step and a big change, and it sounds like that. So that was what led you to go to your GP.
Yeah.
So how has that changed things for you?
Do you know, it's kind of, I haven't really told anyone, so I mean, it's made it like better in the sense that I feel hopefully this is it, like it'll help. But I don't know, I don't like thinking that I've had to do this. I never thought I'd like be the kind of person who'd have to actually go and like get help, if that makes sense.
Okay. So how do you feel about being here today?
A bit like scared. I don't know, hopefully it will help.
Okay. So you've been feeling a little bit anxious about today.
Yeah.
Okay, so I guess just going back to why you went to the GP and how you've ended up kind of coming here today. So it sounds like you've been experiencing anxiety for quite a few years, but just recently you moved out of home for the first time, and that was what kind of led you to go to the GP. So how did that change things? How were things after you moved out?
I thought that they'd be better, but because I thought I'd have to kind of be independent and...
All right, I'm going to stop it there. All right. And I'll give you some time to finish completing your structured, what's it called? The structured clinical observation handout. Yeah. And then we'll share some answers if that's okay. So I'm just going to go, yeah, so we'll do the calibration. So does anybody want to share what they observed in that first 2 minutes in the opening phase? What was the actual observation? What do you think that microskill or the observation actually represented according to the variable you observed? And did you include an analysis? Does anybody want to go and share? Thank you, Javier. Yeah.
I wrote down she had a very anxious voice, rubbing her hands, leaning forwards and backwards, anxious about, I think it was leaving home. The therapist asked an open question, just appearing to settle her down. The client was agreeable. They were building rapport and moved on to, restating the actions within the timeline. So the therapist could understand it.
Yeah. All right. So great. You put a lot in there, actually. There's a lot more. Thanks, Libby. I'll get to you. Yeah, there was a lot. So your first one, you said she was really anxious. All right. So was that was an observation, or what did you observe to identify that she was anxious?
Just the difference in the tone and pitch of her voice, the forwards and movement, her body movement, a little bit forwards and backwards, the way she was averting her gaze and then looking, rubbing the hands.
So let's stop that. Yeah, so they were all observed. So you watched her rub hands, averting her gaze, and I think you said her voice was shaky or something like that, right? Yeah, which are all of their perfect observations in the left column. The word anxious, though, where do you think that it belongs in column, on the right column under data, or where should that go?
Probably in the right under analysis.
Yeah, that's where I would put it too. So yeah, and rightfully so. In your experiences, those combinations of kinesics, it's probably under the term, under Hill's variable of kinesics. That's in your experience, that indicates anxiety. So you would put anxiety under analysis. Yeah, absolutely. Yeah, so that was a good start. So Libby, would you like to add to that?
I think I just wanted to note the number of times she chewed her bottom lip.
Yeah, another good observation. She chewed her bottom lip. So in the microskill bit, under Hill's list, not that it's in front of us, but what would you say is the variable you've just observed? Again, would that be kinesics, with body language, you know?
Body language.
Yeah. Okay.
Yeah.
And then have you got an interpretation or an analysis there related to biting of the bottom lip?
I would say anxiety as well.
Anxiety as well.
Yeah.
So does everybody understand that?
From my culture, from my experience.
That's right.
The thing.
But what's good is, so what's good is you've separated that though from column one. So the column one data is one set of data, absolutely. And that analysis column can be another set of data, but at least the two have separated now. Yeah. So if we look at that ladder, the data column is the rung 1 data. That analysis column is probably that rung 3 data. Yeah. Does that all make sense? Any questions so far on what we've talked about so far? On separating the two types of data. Natalie, yes.
Hi, thank you. Just a really quick question. I can't remember. It's been one of those days. Was it stated right at the beginning that did the client actually state that they had anxiety or they were coming for anxiety? Did they state it?
I think she did.
I think she did. Because if the client states it, I'm thinking like if you're subpoenaed, you're going to get integrated in the courtroom, in the witness box. That could easily be argued if you were given, if you said that in your analysis that it was anxiety, couldn't they just sort of say, well, that's what the client said they were coming for? Am I being a bit too
So
would we have to actually explain our analysis on how those am I getting too deep on that? Would we have to explain our analysis to why it is anxiety, like why that body language is anxiety? Do we have to? Because I mean, are we assuming it?
And that's why it's in column 3.
Okay.
Because that's your interpretation of that behaviour. And indeed, she said she's anxious, but indeed, I'll invite you to say, just because her use of the term anxiety, not necessarily is your understand, you have to unpack it. Yeah. So I'm hearing from you this anxiety about your analysis column against the data column in a courtroom. Is that what I'm hearing from you?
I was just thinking, is it that? Yeah. Yes. Sure.
Yeah. So, I suppose the context of why I'm talking about this is really just to because that exact observation would be in your clinical notes, the clinical notes that you keep as a practitioner when working. So I'm asking you to separate out the observation to the analysis for research purposes. Now, if you were subpoenaed, you would give the lawyer, if he had the proper documentation, not lawyers, as you know, lawyers can be tricky, you would give him the clinical notes, unless, of course, he's interested in your research notes. I don't know a scenario in that. I don't know, but if in the unlikely scenario your research notes are subpoenaed, it's clearly highlighted that yes, she bit her bottom lip. I've got a recording. Can everybody see? I didn't make that up. It's there. And then in the analysis column is, from my clinical judgment, I interpret that as anxiety. And then I went on to treat that woman for anxiety. Here is the data that I collected as anxiety progressed, and as therapy and the anxiety scores went down, the client said she was happy. That's defendable, I would have thought. Am I right, Natalie?
Yeah, no, sorry, I just realised I went practical in the field rather than this is for research. Sorry.
Yeah, that's all good. No, thanks for the question, because if you asked it, maybe someone else thought it. Is there any other questions before we go ahead? All right. So so essentially, I'm hoping I'm helping you understand that your data, your clinical notes need to be separated into observation, rung 1, and your interpretation, rung 3, and they're treated as 2 streams of data. And whether you use both streams depends on the actual research question or variable that you're actually investigating, experimenting with, having doing research on. All right, so let's keep going. So this is that slide, and I said to you, you know that right-hand side, that column where you put all your analysis. All right, it's not noise. It's not dirty. It is data, as I said, and it's your reflexivity. That's your stuff. That's the therapist data, the interpretation, the analysis. Is data in itself, and sometimes your analysis can be considered research data. Okay, so the therapist is also a research instrument. Okay, you might be interested in researching about countertransference. So that data on the analysis side is rich when you're investigating maybe the countertransference. It's also, that analysis side is also beautiful data that you have to bracket out when you're doing your positionality statement. You're trying to tell the reader, okay, this is me, this is what I'm adding to the data. And you may interpret it different, but this is the way I'm interpreting it because this is me. So that's called bracketing. All right, does that all make sense? Yeah. And it also gives you an audit trail. You use your reflexive noticing log to track state changes if that's if research calls for that. So far, so good. So that I'm just bringing up So that right side, the analysis side, is just as important as the observation, the objective description data. So keep both, in other words. Ethical considerations and everything I've said today. If you are doing your job as a therapist, but are doing your and using your clinical notes or being structured in your clinical notes in this SEO way in order to answer a research question, the client has to be informed that your notes are not just clinical notes, they are also research notes. And why are you doing that? So always, there has to be informed consent that the notes you're collecting are for research. Make sense? Also, your data, although maybe in the raw data stage, it's identifiable to a particular participant. When it gets stored, you will anonymize it. So you have to remove identifiers from your SCO sheets immediately, so that if someone gets their hands on it, they can't identify what client the data relates to. All right, so it has to be anonymized. Some people use coding, and then, for instance, an SCO form might have P1 on it, and on a sheet of paper somewhere else locked away, you'll have a piece of paper that says P1 equals and the name of the client, so the actual data, SCO data, and the actual patient is completely separated. All right. And of course, data security. So all your research data, just like your clinical notes, are stored in a secure location. All right, so they're the ethical considerations when it comes to your collecting data for research, just like clinical notes, exactly the same. All right, from notes to research. So, yep, you're observing your data, you're being very standardized in your observation, you're using your SCO sheets to record or turning your observations in therapy into research notes. Then, and you do that per session. You've maybe had 10 sessions with a client and you've decided, okay, I need to aggregate my data. So that'll be the next stage. So you might collect 10 of these SCO data and aggregate it together, and that's called analysis. We'll talk about that later, which is like pattern recognition based on our data, looking for patterns, and then publication. So that's generally how it goes. We observe our data, we aggregate the data, we look in our analysis, we look for patterns, and then we report on those patterns with the data all anonymized and non-identifiable, and that's ready for publication in maybe a case study or maybe a process note or something like that. So that's how your notes turn into research. Making sense so far? All right. Okay. So this is just a little sort of challenge for you over the next week, or indeed next 2 months. Maybe download your SCO form and have a go of doing that in real life, and do reflect on how and notice if your rigorous observation at that rung 1 level does change how you do your SOAP or your DAP clinical notes differently. If you concentrate more, or you're more aware of how your notes are actually observations plus your analysis and able to separate the two. Does that make sense? All right, so let's talk a little bit more about research. So your clinical practice and your structured clinical observation tool notes that are done inside a clinical practice become data. What do they become data for? They can become data if you're doing quantitative data sort of research, such as frequency counts, or doing reporting on duration of an observation. For example, duration of silences or something, or ratios, really depends on the research question. Or that data can become part of a qualitative research. For example, you might do conversation analysis, thematic analysis, maybe not so much discourse analysis, that's very advanced, but at least thematic analysis or conversational analysis. All right, so this data is beautiful for that style of research. When you've done your conversational analysis or thematic analysis, that can be turned into the types of research that are called systematic case studies, process outcome research, or autoethnographies. The autoethnography type of research can very much be drawn from the analysis column in your SEO data. So really observing your own reflections of your own experiences of being a practitioner in the therapy room. So yourself as researcher as well as participant is an autoethnography, and we can talk about that down the track as well. Any questions on that so far? All right. This is how, if you adopt the SEO way of collecting data, this is how you might write it up in an eventual research paper. For example, data, you might have a section in your method section of your paper called data collection, and you might write it up like this. Data was collected using a standardized, structured clinical observation protocol immediately following each therapeutic session. The SEO protocol distinguishes between low inference behavioral descriptions, that is the left column, and in written columns, we're actually naming the middle column. In this instance, we're observing verbatim utterances and non-verbal kinesics. And high inference clinical interpretations, that is the right column, to minimise hindsight bias. In brackets, Hill et al. 2005, which talks all about SEOs and all those examples. Interventions were coded using categories derived from Hill's counsellor verbal response mode category system. And additionally, the therapist maintained a reflexive noticing log to document countertransference and somatic responses, serving as an audit trail to enhance the confirmability of the qualitative analysis. So we've actually, I've introduced to you today all those aspects of being very standardized in your observations in terms of what you observed, what's it actually called, your analysis. And in this instance, the analysis column is the reflexive noticing log in this instance. Does that all make sense? Yep. Obviously, as I've said, I'm just going to reiterate, when it comes to research, ethics is so important. If you are doing this to either present at a conference or to publish, and ideally both, yes, you do need an ethics board approval. You can't just go and do this. You're not allowed to collect data until you have been approved by an ethics board. Generally speaking, any university have ethics boards, but there are some private ethics boards out there. But generally speaking, the ethics boards, what they're interested in is how you get informed consent and how you're going to do it, how you're going to protect your participants, how you're going to anonymize your participants, etc. These are all the things that you need to explain quite deeply in the ethics form. And I'm not going to teach you this because you as practitioners are not expected to know this stuff. If you wanted to do research where you need ethics approval, I always say get yourself an academic partner or someone who has access to an ethics board, and that person will do the ethics application side of things. All right. So that's the end of what we're talking about. We're actually like 7 o'clock, so I did get through it, but with not much space for questions, but happy to handle, stay behind. But these, on this slide, is all the papers that I referred to prepare today's presentation for you. I'm happy to share these slides so that you have all these papers so that you can go away and pick out any of these. But let's end there now and answer any queries, questions, confusions at all before we end tonight's session. Yeah.